Pediatric Vasculitis Philip Ashks, MD, MSc. Head, Pediatric Rheumatology Unit, Shozadek Medical Center, Jerusalem. Conflict of interests disclosures and off-label medications. No conflict of interest disclosures. Off-label medications and talk. Rituximab for Wegener's granulomatosis. Mycophenolate for Wegener's granulomatosis. Infliximab for Takayasu arteritis. Evig for polyarteritis nodosa. Objectives. When to suspect and how to investigate vasculitis in children. To describe the new classification of childhood vasculitis. To expound on several specific vasculitis entities in children highlighting recent developments. Definition. Inflammatory and destructive process of blood vessels. Inflammation must be present in wall of blood vessel. When to suspect vasculitis. Unexplained multi-system features, especially FUO, weight loss, rashes, hypertension, edema, arthritis, neurologic symptoms. Unexplained tests indicative of inflammation. Elevated DSR, SHE. Anemia, leukocytosis, eosinophilia, thrombocytosis. Low or high complements, low albumin, elevated globulin. Hematuria, proteinuria, systems most affected. Skin, purpuric rash, nodules, livedo reticularis. Gastrointestinal, pain, hemorrhage, infarct. Renal, glomerulonephritis, hypertension. Lung, pneumonitis, hemorrhage. Musculoskeletal, arthritis, myositis. Cardiovascular, ischemic heart disease. ENT-obstruction, chronic OM, sinusitis, nosebleed. Systemic features, fever, weight loss. Nervous system, central nervous system. Headaches, stroke, tear, seizures, movement disorder. Peripheral nervous system. Palsy, especially drop foot/hand. Sensory. Polyneuropathy, mononeuritis multiplex. Vasculitis, investigations. Signs of inflammation. ESR, SHE, CBC, immunoglobulins, complements, albumin, von Willebrand antigen. System involvement. Liver, renal, urinalysis, muscle, pulmonary functions, ENT, GI, eye, brain. Autoimmunity, autoantibodies. Antinuclear antibodies, rheumatoid factor, ANCA, cryoglobulins. Red blood cell count. Fresh first AM urine. Antineutrophil cytoplasmic antibodies, ANCA. CANCA, cytoplasmic. PANCA, perinuclear. Possibly pathogenic, activation of PMN. CANCA antigen, BioLisa, neutral serine proteinase 3, PR3. Specific for Wegener's granulomatosis. Sensitivity and specificity greater than 90%. PANCA. Antigen by ELISA, myeloperoxidase for microscopic polyarteritis. Other antigens seen in ulcerative colitis, other connective tissue diseases, sclerosing cholangitis. Vasculitis, investigations, CONT. Infectious tests, cultures, serology. Streptococcus, hepatitis B, C, HIV, parvovirus. ECG, echocardiography. Electromyography, nerve conduction. Imaging. Chest, sinus radiographs/CT. MRI, brain, neck, cardiac, abdominal. Angiography. Formal, MRA, CT angio, PET scan. Biopsies. Skin, muscle, nerve, renal, lung, other. New pediatric classification by size of vessel. Large arteries, predominantly. Takayasu arteritis. Medium arteries, predominantly. Kawasaki disease. Classic polyarteritis nodosa. Cutaneous polyarteritis. Ozenes, et al. Anrumtis 2006 65 to 936 to 41. Classification by size, cont. Small vessels, predominantly. Granulomatous. Wegener's granulomatosis. Churg-Strauss vasculitis. Non-granulomatous. Microscopic polyangiitis. Hennix-Sconine papyra. Isolated cutaneous leukocytoclastic vasculitis. Hypercomplementemic urticarial vasculitis. Other primary pediatric vasculitides. Behçet's disease. Isolated vasculitis of the SNES. Cogan's syndrome. Unclassified. Secondary vasculitis, connective tissue disease, SLE, RA, sarcoidosis. Infection, SBE, hepatitis B, C, rickettsia, HIV, sepsis, TB, syphilis, gonorrhea, meningococcal, parvovirus. Drugs, penicillin, cephalin, sulfur. Malignancy, lymphoma. Genetic autoinflammatory syndromes. Pseudovasculitis myxoma, cholesterol emboli. Blood vessel, thrombotic disease. Antiphospholipid antibody syndrome. Congenital conditions. Mid-aortic syndrome. Ehlers-Danlos syndrome. Other rare syndromes. Other methods of classification. Pathology. Necrotizing/leukocytoclastic vasculitis. Polymorphonuclear cells. Polyarteritis nodosa, Hennix-Sconine papyra. Granulomatous. Wegener's granulomatosis, Takayasu's arteritis, Churg-Strauss. Systemic versus isolated, skin, SNES, organ. Case description. 16-year-old female with recurrent otitis with effusion for 1.5 years, tubes placed. 1 month of arthritis, low-grade fever, tingling in leg. Chest X-ray, nodule in LLL. ESR of 98. Cyanca positive. Wegener's granulomatosis, WG. Necrotizing granulomator of upper and lower respiratory tracts, kidneys. Small to medium-sized vessels. Rare in childhood, 1/106/year, mode in young adults. Male 2, female 1. Systemic disease versus limited to upper respiratory tract. WG, clinical manifestations. Systemic features 90 to 95%. Fever, malaise, weight loss. Arthritis, 55 to 65%, large joints. Skin, nodules, ulceration, papyra, 23 to 50%. From 4 series of 130 patients. Largest from the Archive registry, N equals 65. Cabraldi, et al., Arthritis Room 2010 60 to 3413 to 24. WG, clinical manifestations. Upper respiratory tract, 80 to 90%, 20% presenting symptom. Chronic rhinorrhea, epistaxis, nasal crusting, sinusitis, otitis, 40 to 65%. Nasal septal necrosis, saddle nose. Biopsy frequently non-diagnostic. WG, clinical manifestations. Subglottic stenosis, 14 to 41% in children. More common with clinical significance than in adults. Stridor, hoarseness, respiratory distress. WG, clinical manifestations. Lower respiratory tract, 80 to 90%. Pneumonia, pneumonitis, 23%. Hemoptysis, 44%, nodules, 42%, pleural effusion, pneumothorax. Abnormal pulmonary function, 78%. WG, clinical manifestations. Renal, 80 to 90%. Abnormal urinalysis, 75 to 88%. Glomerulonephritis, focal, segmental, diffuse, 52 to 64%. Hypertension. Elevated creatinine, renal failure, 42%. WG, clinical manifestations. Uveitis, scleritis, episcleritis, proptosis, pseudotumor, 37 to 53%. Nervous system, 25%. Peripheral neuropathy. WG, investigations, signs of inflammation. Urinalysis, renal function, collection. Radiographs/CT. Pulmonary function tests. C-ANCA, positive greater than 90%. Debate if can use ANCA to monitor disease activity. WG, investigations, biopsies, skin, nasal, sinus, lung, renal. Upper respiratory, frequently non-diagnostic. Vasculitis, capillaritis, granulomas. WG, differential diagnosis. Infectious, TB, fungal, syphilis, leprosy. Inflammatory, microscopic polyangiitis, sarcoidosis, Goodpaster's, Loeffler's syndrome, other vasculitis. Lymphoma. WG, pediatric classification criteria. Histopathology, granulomatous vasculitis/perivasculitis. Upper airway involvement. Laryngotracheobronchial stenosis. Pulmonary involvement by chest X-ray/CT. ANCA positivity. Renal involvement, proteinuria/hematuria/biopsy. Need 3 of 6, 93.3% sensitivity, 99% specificity. Ozenes, et al. Anrumtis 2010 69, 798 to 806. WG, treatment, 100% mortality within months without treatment. Induction, corticosteroids, oral cyclophosphamide versus rituximab. Cyclophosphamide, many side effects, infections, neutropenia, hemorrhagic cystitis, bladder carcinoma. Corticosteroids alone doesn't prevent death. Methotrexate induction in milder cases. WG, rituximab anti-mature cell, CD20, antibody. Recent trial, RAVE, of 197 patients including adolescents from age 15 years. Equal efficacy in inducing remission, less relapse rate than cyclophosphamide. Equal adverse effects, followed only for 6 months. Stone J.H., et al., Nejm 2010 semicolon 363 to 221 to 32. WG, treatment, cont. Maintenance, methotrexate, azathioprine, mycophenolate. For at least 2 years. Trimethoprim sulfamethoxam in limited disease. May prevent flares in nasal staphylococcus carriers. Prophylaxis for PCP. Other therapies. Anti-TNF, etanercept not effective, less safe, malignancies, vascular thrombosis. Topical steroid injection, dilations for subglottic disease, WG, prognosis remission obtained in greater than 90%, greater than 50% will relapse. Greater than 80% 5-year survival. Disease-related deaths. Respiratory, renal failure. Treatment-related. Infections, malignancies. Children more severe upper respiratory than adults, less renal disease. Microscopic polyangiitis. Small vessel vasculitis. Glomerulonephritis. Pulmonary manifestations. p-ANCA positive in 80%. Myeloperoxidase. Treatments and prognosis similar to WG. Churg-Strauss granulomatosis. Medium-size arteritis with granulomas. Eosinophilia, Pianca, 40%. Asthma, like attacks. Pulmonary infiltrates, non-fixed. Frequent allergic history. Mononeuritis multiplex common. Less renal involvement than WG. Very rare in childhood. Case description. 15-year-old female, Asian ancestry, with 2-month history of low-grade fever, weight loss, malaise, headaches, exertion, right leg pain, 2 episodes of syncope. Examination, severe hypertension, decreased pulses in neck, left hand, right leg pulses. ESR-90, HB, 9.9, ANA and ANCA negative. Abdominal Doppler US-renal artery stenosis, Takayasu's arteritis, TAE. Also pulseless disease. Young less than 40 years. 1/3 less than 20 years. Asian, African American females. Incidence 1.2 to 2.6/106/year. Large artery vasculitis, aorta, aortic arch, carotid, subclavian, renal, iliac, TA. Clinical manifestations. Systemic, 65%, fever, weight loss. Hypertension, 85%. Palpitations, dyspnea, syncope. Headache, 50%, visual disturbances, 30%, dizziness, syncope. Arthritis, arthralgia, myalgia, 65%. Gastrointestinal symptoms, 50%. Claudication, walking, upper extremities. TA. Physical examination. Hypertension. Decrease in pulses. Differential blood pressure in limbs. Measure for limbs. Brutes, carotid, subclavian, aorta, renal, femoral arteries, 70 to 80%. Signs of aortic insufficiency. Growth abnormalities, atrophy of affected extremities. TA. Children versus adults. Children usually have the triad. Systemic features, hypertension, elevated DSR. More systemic features, renal artery involvement, less claudication than adults. TA. Pediatric classification criteria. Angiographic abnormalities of the aorta or its main branches and pulmonary arteries showing aneurysm/dilatation, narrowing or occlusion not related to fibromuscular dysplasia, mandatory criterion. Plus one of the 5 following criteria. Pulse deficit or claudication. Forelimbs BP discrepancy. Brutes. Hypertension. Acute phase reactant. 100% sensitivity, 99.9% specificity. Ozenes, et al. Anrumtis 2010 69, 798 to 806. TA. Classification by location, type of lesion. Type I, aortic arch. Type 2, thoracic and abdominal aorta. Type 3, diffuse aortic involvement. Type 4, aortic and other arteries. Obstructive lesions, US, Japan. Aneurysms, India, Africa. TA-other clinical associations. Autoimmune. Crohn's, immunodeficiency. Infectious, TB in developing countries. Many patients with positive TA-investigations, signs of inflammation. ESR important in following course. Elevated factor 8, related antigen. Rheumatoid factor, 25%. Hypergammaglobulinemia. Imaging modalities used. Ultrasound, Doppler. Echocardiography. Formal angiography. MRI/A. CT angio. PET scan. TA. Imaging angiography. Also important for central blood pressure measurement. MRI/M.R.A. Wall thickness and edema in addition to detecting stenosis/aneurysms. Less invasive for follow-up. Imaging finding stenosis, 85 to 98%, occlusion. Dilatation, aneurysms, 2 to 27%. Mixed. Collateral formation. Wall thickening, edema. TA-pathology, rarely obtained. Panarteritis, focal, segmental lesions, including vasa vasorum. Loss of muscular, elastic tissue, giant cells, granulometer, intima and media hyperplasia and fibrosis. TA, treatment corticosteroids follow ESR, imaging regularly. Methotrexate. Cyclophosphamide. Anti-TNF, infliximab. Bypass surgery. Only when inflammation subsided. Balloon angioplasty less effective, stent not effective. TA, natural history course. Triphasic. Pre-inflammatory, inflammatory, burnt, out. Remission and relapse, 80%. 20% only one course of disease. TA, prognosis. Hard to determine and correlate disease activity and vasculitis progression. Bad prognostic signs, hypertension, congestive heart failure, syncope. Greater than 90% 5-year survival. Death, aneurysm rupture, myocardial infarction, stroke, cardiac failure. Morbidity, from hypertension, ischemic damage. Case description. 10-year-old male, developed fever, muscle pain, rash 1 week post-strep. Physical exam nodular and livedo-reticularis rash, tenderness over muscles. ESR, SP increased, anemia. Deep skin/muscle biopsy diagnostic. Polyarteritis nodosa, PAN. 2 types, classic and cutaneous. Rare in childhood. Unlike adults, rarely associated with hepatitis B. May be associated with streptococcal infection, especially cutaneous PAN. Associated with familial Mediterranean fever. Peak age 9 to 11 years, sex, equal distribution. PAN, clinical manifestations. Systemic features, 94%. Fever, weight loss, splenomegaly, insidious. Rash, 50 to 60%. Arthritis, myalgia, 50 to 60%. Gastrointestinal, 67%. Pain, malabsorption, diarrhea, infarct. Cardiovascular, 44%. PAN, rash. Palpable purpura. Nodules. PAN, rash. Ecchymosis. Gangrene. Ulcers. PAN, rash. Livedo-reticularis. Splinter hemorrhage. Systemic PAN, clinical, cont. Renal, 83%. Hypertension. Renal artery stenosis. Glomerulonephritis to renal failure. Nervous system, 40%. Central, seizures, psychosis, stroke, coma. Peripheral, mononeuritis multiplex. Other, testicular swelling, claudication, PAN, pathology fibrinoid necrosis of medium-sized muscular arteries. Acute and chronic. Partial thickness, segmental, skipped lesions. Mainly at bifurcation. PAN, evaluation signs of inflammation. ESR, SHI, WBC, anemia, immunoglobulins. Urinalysis. Hepatitis B rare, strep. Serology. Factor VIII related antigen, neopterin. Endothelial activation. Negative ANCA, PAN, evaluation, cont. ECG, echocardiogram. Nerve conduction, electromyography. EEG. biopsy. Skin, muscle, sural nerve, renal. Pan, imaging MRI/ACT angiography. Often difficult to image smaller vessels, pan, angiography renal, celiac, coronary, eyes. Segmental aneurysms, stenosis. Beading. Pan, pediatric classification. Histopathology or angiographic abnormalities, mandatory. Plus one of the 5 following criteria. Skin involvement. Myalgia/muscle tenderness. Hypertension. Peripheral neuropathy. Renal involvement. 89.6% sensitivity, 99.6% specificity. Ozenes, et al. Anrumdis 2010 69, 798-806. Pan, treatment. Mortality of systemic pan 100% when only corticosteroids used. Cyclophosphamide induction. Azathioprine, methotrexate maintenance. EVIG in some resistant cases. Newer therapies not studied. Consider penicillin prophylaxis when streptococcus involved, especially cutaneous disease. Pan, prognosis better with aggressive therapy, 5-year survival 60 to 85%. Deaths from GI, renal involvement. Treatment side effects. Minimal mortality in streptococcus-associated cutaneous disease. Case description. 8-year-old male presented with severe headaches and seizure, focal. Family reported decrease in school ability in last 2 months. Inflammatory markers and autoantibodies normal. Lumbar puncture increased protein levels. MRI infarcts/inflammatory lesions in brain. Narrowing of multiple arteries confirmed by angiography. Isolated SNES vasculitis. Rare. All ages groups. 4 major types. Viral-induced, varicella. Non-progressive, 1 blood vessel. Progressive. Larger vessels, angiography positive. Smaller vessels, angiography negative. Presentation of SNES vasculitis. Cognitive dysfunction. Severe headaches. Thunderclap. More frequented in non-progressive disease. Stroke. Seizures. Mental status changes. Laboratory tests unrevealing in large vessel disease. Increased inflammatory markers in small vessel disease. Lumbar puncture. Most common increased protein. Increased local egg production. Pleocytosis. Imaging MRI/ACT angiography, formal angiography. Important for distal vasculitis. Stenosis, beading. Pathology. In order to diagnose small vessel vasculitis, biopsy is necessary if vascular imaging is normal. Perform an area of MRI abnormality. Leptomeningeal. Often granulomatous. Treatment. Relative short course of steroids in non-progressive vasculitis. Steroids and cyclophosphamide induction for progressive vasculitis. Azathioprine maintenance. Anticoagulation/antiplatelet. Prognosis: poor prognosis in untreated progressive disease. Multifocal, distal vessels, cognitive dysfunction. Good mortality prognosis in non-progressive disease but may be significant residual damage and functional disability.